Congress organization, they tell me that the next pair, that is Nicola Normanno, is entering the teleconference. And so maybe what we can do is to introduce, I can introduce the next speaker in order to, not to avoid that we are stopping our flow of conference. And so we are moving now to the second session of metastatic disease for targeting agents. And the next will be on two very famous or infamous targets that are respectively MET and KRAS. And the next speaker is Dr. Jürgen Wolf. Please, you can start your presentation. Thank you.
Hi, can you hear me?
Yes, we can.
And can you also see my slide?
Yes.
Okay.
Screen presentation? Okay, perfect.
Okay, perfect. So we can start. So thanks a lot first for the kind introduction and also for the invitation. It's really a pleasure for me to give this talk here. And like we see in this session, systemic therapy of lung cancer is increasingly and really impressively molecularly guided now. And I'm happy now to give an update on two of these targets. First, the MET dysregulation, and second, the KRAS mutation. And all these targets have fundamental changes in diagnostics, treatment, and fortunately also in the outcome for our patients. So MET dysregulation is known already for a long time as an oncogenic factor in lung cancer, and we are all familiar since a long time with the MET copy number gains, either as polysomere or as true amplification, as shown here on the right side of the picture. And the frequency depends on the gene copy number level. So it's around 4% if we focus only on high level with a threshold of 6 copies, and it's only 1% if it's 10 copies. So more recently, the MET exon 14 skipping mutation, as shown schematically on the left side here, has been characterized. And the mechanism here is that the MET exon 14 skipping leads to an increased turnover of the protein and decreased half-time. And this means, this triggers the oncogenic function. The frequency here is 3 to 4%. And these patients are a special subgroup with a higher average age and a higher percentage of never smokers and of female patients. So there are different ways to inhibit MET, and I want to focus today on the kinase inhibitors. We are all familiar since a long time with the non-selective MET kinase inhibitors, in particular with the crizotinib, which is also active against ALK and ROS. And the major focus today will be on the new highly selective MET kinase inhibitors like the capmatinib and the tepotinib. Both drugs since last year now approved for advanced NSCLC with MET exon 14 mutations in the USA and Japan. Capmatinib also now in some other countries, and we expect approval for both drugs soon also in Europe. So last year there were 3 key papers for MET inhibitors in MET exon 14 NSCLC. And the first one by Alex Trillian in Nature Medicine, a phase 2 trial of crizotinib. And we saw pretty well efficacy. So overall response rate in this trial, which includes a mixed population with a majority of relapsed patients with MET exon 14, 65 patients altogether. Overall response rate was 32%. Median duration of response 9 months, and progression-free survival 7.3 months. There was not a strict separation between first line and relapsed patients. Then we saw the data for the capmatinib in MET dysregulated NSCLC, the Geometry Mono 1 trial. And this was a multi-cohort trial focusing on the one hand on the MET exon 14 mutated patients, on the other on the MET amplified patients in several cohorts with different gene copy numbers. I will go into this into more detail later. And the trial also separated strictly between pre-treated patients and treatment naive patients. So the baseline characteristics correspond pretty well to what has already been described for this subgroup. So a higher age, 70 years here, a higher percentage of female patients, 60% here, and of never smokers, also around 60% here. And this on a first glance, you see it's a pretty well effective drug. The pretreated patients here on the left side, the treatment naive patients on the right side, deep responses. And these deep responses were seen independently. This is shown here. I think it's not necessary to go too much into the detail, but just to summarize, as the efficacy was independent of the type of MET mutation leading to the MET exon 14, means whether it's a single nucleotide variation or an intel, and the mutation, which has some practical relevance for routine diagnostics, could be detected with a very comparable sensitivity, both with the RT-PCR, which was a clinical trial assay, and an NGS assay. So I want to show you as a primary endpoint here the overall response rate from the initial results published last year and underlying approval, and from independent confirmatory cohorts shown on ASCO this year. So let us start with a pre-treated patient, cohort 4, cohort 6. You see initial report in a mixed cohort of second and third line patients, 40% response rate, and now in the independent cohort, strictly second line, 52%, and a higher efficacy in the first line. So last year reported 68% overall response rate, and now these were 28 patients, and now with 32 patients in an independent confirmatory cohort, 66 patients, nearly identical. So we also know the median PFS now, it's around 6 months. In the pre-treated patients, it's around 11 months. In the first line patients, also pretty consistent in the independent cohorts. And this year we saw also for the first time the overall survival results in the pre-treated patients around 14 months and 21 months in the treatment naive patients. So a safety summary, this is very comparable between the different MET TKIs. So I show you only the data now for the capmatinib, but this is very comparable with the tepotinib and also with the crizotinib. So a typical side effect are the peripheral edema. So this is seen in nearly half of the patients if you consider all grades of toxicity, but it's unfortunately rarely grade 3, 4, so below 10%. And you have GI side effects like nausea, vomiting, sometimes vomiting, diarrhea, decreased appetite, but this is mostly grade 1, 2. And then there is also typical for MET TKIs an increased blood creatinine, but this does not show necessarily an impairment of the renal function, but rather an interference with a creatinine transporter in the serum. So discontinuation due to treatment-related adverse effects was only necessary in around 10% of the patients. So then we saw the phase 2 trials of the VISION trials, the phase 2 results of the VISION trial in MET dysregulated NSCLC, and very comparably to capmatinib, they analyzed the efficacy of the drug in MET exon 14 skipping mutated patients and also in MET amplified patients last year. We saw the efficacy result for the exon 14 patients, also underlying approval of the drug. And so the mixed result for the first line and the relapsed patients is an overall response rate of 46%. This is very comparable with the results for capmatinib, and also there was not a strictly statistically separated analysis of first line and relapsed patients. We also saw for the tepotinib higher efficacy in the treatment naive patients. So median duration of result also comparable with the capmatinib, 11 months, PFS 9 months in the mixed population here. And this trial also allowed to recruit patients based on liquid biopsy. So capmatinib was only tissue biopsy. And it's interesting, and I think a relevant result, that the efficacy data were exactly the same whether liquid biopsy or tissue biopsy was used for inclusion into the trial. And the authors of, or the investigators of VISION presented an impressive resistance mechanism analysis based on repeated liquid biopsies this year on ASCO. It's summarized here. And what they showed is that there are different, like we know it for other kinase, resistance mechanisms, kinase inhibitor resistance mechanisms, on-target and off-target mechanisms. So they found MET mutations, MET amplifications. They found TP53 and RB1 loss, TP53 mutation and RB1 loss, also amplification of the EGF receptor of HER2, and also mutations in KRAS. And I think this is the first step to develop maybe a next generation MET inhibitors or combination therapies effective in resistance. So both capmatinib and tepotinib also show a very comparable CNS efficacy. So both trials reported these results in a restricted number of patients, around 15 patients, and they showed around 50% of the patients with a true intra-CNS responses based on the RANO criteria, and in a restricted number of patients, about around 90% intracranial disease control. And both trials now also have shown results on the efficacy of these inhibitors in MET amplified patients, but this is a little bit more difficult to compare. So this is a geometry trial for the capmatinib published last year. So overall response rate in the pre-treated patients 30%, and in the treatment naive patients 40%. But here this was only in a cohort with a gene copy number of 10 or more. All the other cohorts with a gene copy number of below 10 were negative. And here we have now the vision results presented this year on ASCO. Here, the gene copy number by NGS in liquid biopsy was determined with as a high level, or inclusion criteria was 2.5 or more. And if you look into the relapsed patients, it's very comparable with the 30%. But in the first line patients, it's 70%, but this is based only on 7 patients. So I think we have to be careful with any interpretation. It shows efficacy, not as effective, both drugs as a MET exon 14. And I think we need more data here, and also a more careful comparison of the diagnostic methods. So to conclude, for the MET exon 14, skipping mutations now are definitely established driver mutations. We have seen these 3 highly published trials and these 2 approvals last year, and detection should be part of a routine molecular diagnostic workup. Capmatinib and tepotinib have shown high efficacy in this subgroup. They both are approved. Activity in the first line is better. They are well tolerated. So they should be considered as a standard treatment. What we also have learned is that MET exon 14 can be diagnosed in liquid biopsy using NGS. However, and I think this is of practical relevance, if liquid biopsy result is negative, sensitivity is not enough to exclude the patient from this treatment. Tissue biopsy then should be performed. So in MET amplified NSCLC, results with some limitations, which I have discussed, are somehow comparable, but there are still many open questions. I think it's definitely an option if you have a patient after routine standard therapy and you have high levels and you know that these drugs are effective and there is no other treatment, or only maybe docetaxel with a 10% efficacy, then it's worth to try this option for the patient. So now, the second part of my talk, activated KRAS as a cancer gene, and not only as a cancer gene, but only as a target for cancer therapy. So just want to remind you, also most probably everybody knows, but sometimes if you compare the different new drugs, I think it's important to remind that this is not a typical receptor kinase. This is a GTP binding protein, so completely different mechanism, and it strictly regulated the active state between the inactive forms, the GDP bound KRAS, and the active forms, the GTP bound KRAS. And this equilibrium here is tightly regulated by 2 groups of molecules, the GAPs, the GTPase activating proteins, and the GEFs, the guanine nucleotide exchange factors. And I also want to remind you that it's not only the classical downstream pathways, RAS, RAF, MEK, ERK, like we have learned it, and the PI3 kinase, ACT and TOR. There are several other pathways which are triggered and stimulated by mutations in KRAS, and there is a strong interaction between these intracellular signaling pathways and signaling pathways in the compartments of the tissue microenvironments, inflammatory cells, T and B cells, myeloid cells. And there are different strategies to target KRAS, and the focus today, because it's the only approved drug now, are the KRAS G12C inhibitors. So the mechanism is a direct binding to the inactive GDP KRAS, thus preventing the formation of the active GTP-RAS. There are also other strategies like the SHP2 inhibitors, which act on SHP2, which is between the receptor, downstream of the receptor, and the CHEF complex I have just shown on my first slide, which is responsible for triggering the active state of KRAS. And we have SOS1 inhibitors, which directly interfere with transversion of GDP and GTP. And we have, of course, this is not shown here, a lot of other approaches using specific immunotherapy against KRAS peptides. So sotorasib has been approved this year. So after we have waited for decades for an effective drug in KRAS, and sotorasib is approved now in relapsed after first-line standard therapy. And the approval in the United States, not in Europe so far, is based on the CodeBreak 100 phase 2 trial, very simple trial in pretreated KRAS G12C positive lung cancer, advanced lung cancer. Sotorasib was given until progression. The baseline characteristics are this is a very average lung cancer cohort, and maybe it's worth to mention that nearly 90% of the patients were previously treated with both platinum-based chemotherapy and immunotherapy. The primary endpoint was an objective response rate. So we have seen 2 years ago in ASCO was a 50% response rate. It was a little bit lower, a little bit disappointing, 37.1%. So thus in the moment, it's an open question whether this will be better in the first line, but it's definitely better at everything we know in the second line situation as a therapeutic option for the patient. So we have seen also the PFS data, 6.8 months, and this year in ASCO, the overall survival data with 12.5 months. Safety was a well-tolerated drug. So as you can see here, only 20% of the patients have grade 3 side effects. So we have treated in our center many patients now within the trial. Most prominent side effects, but mostly clinically manageable are the GI side effects like diarrhea, nausea, but you also have to look for elevated liver enzymes. Sometimes it's a rash, but this is not a problem as a rule. So only in 7% of the patients, treatment-related adverse events led to treatment discontinuation. Then they have also looked for efficacy in molecularly defined subgroups. This can be summarized shortly. So they have looked on efficacy dependent on the allelic fractions. There was no difference. They have looked for an association with tumor mutational burden, high and low. You see no difference. And then, but this has to be discussed a little bit more cautiously because the patient numbers are very small. There was no correlation with TP53, STK11, KIAP1. If one looks at this single mutation, but then there was an additional analysis looking for the combination of these mutations. And this analysis shows that improved efficacy was seen in the STK11 mutant group with concurrent wild-type KIAP1, whereas KIAP1 mutant groups seem to have a less benefit but of course this has to be seen in the context of the very small sample size. I think it's an interesting signal and we need more data here. So I also want to remind you that it's not only the sotorasib, there are also competitors, and we also know now for the adagrasib, the KRAS G12C inhibitor, the efficacy of the phase 1 and phase 2 trial. So taken together, Tony Mock has shown this on a poster on ASCO this year. 45% of the patients had a confirmed overall response rate, so very comparable, a little bit better, but I think very comparable. And clinical benefit was observed in 96% of the patients. And like for sotorasib, where a phase 3 trial and second line is now open against docetaxel, also for the adagrasib, now there is a phase 3 trial open comparing this inhibitor with the docetaxel. So I come to my conclusions for the KRAS G12C part. So we have now with the sotorasib a first-in-class inhibitor, which is approved in relapsed NSCLC. Efficacy in second line is not as we have expected, but it's better than what we know for these patients or what we have for these patients at the moment. It's an overall response rate of around 40%, PFS 12.8 months, overall survival 6.5 months. Toxicity profile is definitely favorable. Efficacy has seen across all clinical and molecular subgroups. Several further KRAS G12C inhibitors are in clinical evaluation at the moment. And I think the challenges and the questions are, I think one of the most interesting questions, how will the efficacy be in the first line? Because here the competitor is immunotherapy or chemoimmunotherapy. And you know, the response rate here is 50% and more. And we have seen the update with the chemoimmunotherapy of KEYNOTE 189 with a median overall survival of 22 months now. So I think this will be an interesting question. How will be the efficacy of these inhibitors in the first line setting? And then it's definitely important to look for effective combinations. So a lot of trials are open now, multi-cohort trials testing different combinations, but so far no results. And I think in view of the 40% overall response rate, also a key question is how to explain or how to understand primary and secondary resistance. So with this, I have come to an end, and I want to conclude, and I think this holds true for all talks as a conclusion, for all talks on targeted therapy. Our patients deserve to get the best drug first. We have more and more of these new good drugs. And so I think there is no alternative to an upfront broad molecular NGS-based testing. Thank you again for the invitation and for your attendance.
Jürgen, many thanks for this very nice talk. Sorry, I was late, but it's unusual to be so ahead of schedule for a meeting, and I was in another meeting. So I would like now to start the discussion of your talk. So I invite all the attendants if they to make questions through the chat. Meanwhile, I would start with some of these questions. Now, very nice data. I mean, in subgroup of patients in which, of course, we don't have many other alternatives, or maybe I mean, it's very nice. So always to have new target agents. However, if you look at the response rate of these drugs, it's not what we observe with the EGF receptor tyrosine kinase inhibitors in EGFR mutant cancer or ALK inhibitors in patients with ALK fusions and so on. So is the biology of these tumors different, or we still need to improve with the drugs, or do you think are there any other factor that is affecting the activity of these drugs in these subgroup of patients?
Yeah, I think we have to distinguish between the MET and the RAS inhibitor. This both parts of my talk. I think for the MET inhibitors, for the tepotinib and the capmatinib, I think if you look into first line results with a 70% response rate now confirmed and the median overall survival of around 13 months, I think this is very comparable, for instance, to the first generation EGF receptor TKIs. So, but definitely for the sotorasib, this is a difference, and I think this is why I mentioned that it's the open question: what is the overall response rate in the first line situation? Because the difference is you have already highly effective therapies for these patients. So the benchmark is much higher. And I think unless we know whether there's also this effect that in the first line situation, the efficacy is higher, it's difficult to speculate.
Yeah, I agree. Although for EGF receptor tyrosine kinase inhibitor, at least we saw similar activity in first and second line in terms of response rate. So it looks like something is different also for the MET exon 14 skipping, because there's this huge difference between pre-treated and treatment naive. Do you think that is it true, will be confirmed with larger numbers, or is something that's going to change with the treatment?
Yeah, it's a good point. It's a good point, but we see it also in the next generation inhibitors, in the ALK, or also now the first generation inhibitors with RET. We also see a striking discrepancy between efficacy in first and second line. So to be honest, I cannot explain. I think nobody can explain in the moment. But maybe for the MET, I have the gut feeling it's like a first generation MET inhibitors, and now understanding more on the resistance mechanisms and so on. Maybe we soon will see next generation inhibitors with a higher efficacy.
Yeah, this makes even more important what the message that you gave at the end of your talk. We need to have upfront a genomic screening of all our patients, because only in this way, we can really select. And the data that we have presented at ASCO and the data also that we have from Europe are not really encouraging on this, because many patients do not access to NGS testing, looks like, outside of the academic centers, of course.
Definitely. I think this is one of the major challenges in the moment in Europe and also in our country. So 1/3 of our patients is not tested upfront for all of these markers. And this means thousands of lost patient life years annually for advanced lung cancer, definitely. I think, and I would like to add that it's not only necessary to test upfront, but also during each relapse of the disease to learn more about resistance.
And actually, I mean, we were used to have the drug, and maybe after 2 years to learn about the mechanism of resistance. Now it looks like we have the drug, and at the same time we have also knowledge of mechanism of resistance, PIK3CA and other genomic alteration in exon 14 skipping cancer. Do you think that there is room to propose now new treatments? It would be better to start with combination or to treat the progression? There's always this debate also in the field of EGFR mutant lung cancer.
Again, I would like to differentiate between, or distinguish between the MET and the RAS field. The MET exon 14 patients, they are, on average, they are 10 years older than the average population of lung cancer patients. So I could imagine that, like for the EGF receptor field, there is an increase in efficacy if you combine it with chemotherapy. I think there is it could be a similar mechanism, reducing the clonal heterogeneity from the beginning by additional chemotherapy. So I think this could work also in this patient, but from a practical perspective, looking at these old patients, I have my doubts whether this makes sense. Completely different in the KRAS field. I think if the response rate will not be much better in the first line situation, then it's definitely essential to develop intelligent combinations.
Yeah, but for the KRAS, I was quite surprised that they looked at STK11 or KEAP1. Those are markers of resistance to immune therapy, why they look into the KRAS. Whereas, I mean, there are data suggesting that KRAS G12C is associated with F2 mutation or for mutation amplification. Maybe it was, I mean, if you think a signal transduction, was more wise to look at those genomic alterations rather than looking really at only the presence of KEAP1 and STK11. We have a question from the floor. Do you have any advice for managing edema for MET inhibitors?
Yeah, this is always the same question. So also altogether, it's a well-tolerated drug. This is really a problem, and there is no easy answer. So and it's definitely not a satisfying answer. So what we always try, of course, are compression stockings, and many patients organize for stem cells. So we are doing it also in the moment, a lymphatic drainage. So many patients seem to benefit from this. Then we treat with mild diuretics, but only mild, because these are old patients, and I think the elevated risk of thrombosis and the fatigue if they have not enough water, I think this has to be considered. But these are the tips, let's say. So compression stockings, lymphatic drainage, exercising, movement, and mild diuretic therapy.
Good. Now, we had a very important message from the tepotinib trial on liquid biopsy, because at least it was shown that if you find a meta-exon 43 skipping on liquid biopsy, the chance to respond to patients are similar to the patients that are tested on tissue. And this, I think, the type of data that we need. Still, there's this issue of the sensitivity. So you think that liquid biopsy now will be more and more used by oncologists to drive therapy in their patients?
Yeah, but I think this is a very important and practically relevant, and has also been confirmed for the capmatinib this year on ASCO. I have not shown due to questions, reasons of time. But if you, so my philosophy is we should try to treat these patients in the first-line situation. And then it's not so relevant, because then you have the tissue biopsy. But if there is no result from the tissue biopsy, or not enough, of course, and in particular in the second line or third line situations, this is a very important result. And what I really liked in the VISION trial is that they use liquid biopsy also for looking for resistance mechanisms.
That's actually is very useful, because of course you don't want to have invasive techniques in addition to have a better picture. But still, I mean, there's also to highlight that exon 43 skipping, I mean, you should have a better coverage, maybe at RNA level rather than DNA. But most of liquid biopsy testing techniques are only based on DNA sequencing, and this might be a limit to detect all the genomic alteration leading to meta-exon skipping. So this is another reason why, you know, liquid biopsy is okay, but only if you have an available tissue, most likely.
But
now,
this is very important. Yes, what you just mentioned, I think is very important, because this is such a rare mutation. You should not miss any patient, and it's important. I have not included in my talk, good that you mention it. Definitely, this is also our experience. We have seen a lot of patients, and in a large network, we are doing a lot of molecular diagnostic. Definitely, RNA-based NGS is more sensitive for detection of the exon 14 skipping. Yes.
Yeah, but unfortunately for liquid biopsy, the problem is the RNA is less stable. Still, there are now some new NGS panels based on RNA sequencing. We picked a patient with a meta-exon for resistance skipping by RNA sequencing of the liquid biopsy or circulating cell-free RNA. But still, I mean, this has to be demonstrated in large reports. Now, last point is about MET amplification. I mean, there is room to use in patients with MET amplification, but these data are quite confusing. Which will be at the end the cutoff, 10, 2.5. This is, I think, it's of course we are two different drugs, but it's quite difficult to accept that there are so huge difference in terms of copy number alteration threshold if you talk about biology of the tumor.
Yeah, this is a very good question. Of course, this question has to be expected, and it's good that Alex is now all so here. Maybe he can also comment on this. I think there are two aspects. First, a clinical aspect. So if you see MET amplification, so I think in the moment, based on the data we have seen, it's not an option for a first-line treatment, because what we have seen, these patients, they benefit from immunotherapy or immunochemotherapy. And if these patients then relapse after platinum-based chemotherapy and immunotherapy, and they have a MET amplification, I think it's worth to try with a MET inhibitor, because the docetaxel is not really an effective treatment. But nevertheless, this is a practical view. So I would say let's see it very pragmatic. So it's one relapse treatment option, and we often do it, and we see responses and benefit. But the theoretical part of your question, I cannot answer, because it's such a different cutoff. So we have the gene copy number level of 10, and we in all the other cohorts in the geometry trials, even in the cohort 6 to 9, there was an overall response rate of 10%. And but in the VISION trial, it was a cutoff of 2.5, but based on liquid biopsy NGS. Maybe Alex, you can comment on this.
Yeah, we're doing a lot of work on this right now and hoping to submit this as a paper, but it's a very complicated diagnostic question. I think that the punchline of our paper will be that while we have seen increasing activity across solid tumors with higher levels of true amplification, not just gene copy number, which can result from polysomy. When we looked at our data set, there are some cases with low levels of fold change or copy number increases that still benefit substantially. And that plays also into the heterogeneity. Some of these cells, you have MET amplification broadly in all tumor populations, but particularly for those where it's an acquired event after prior oncogene, it looks like rice and beans. Like you have pockets of MET amplification. And so at least with next generation sequencing, you have an integrated copy number, but that might not reflect actually the focal copy number increase in some of those changes. So go ahead.
No, do you have any evidence that the level of amplification, so it's easy maybe to understand also for the attendance, so the level of amplification might change between first line and second line in patient receiving immune therapy or chemotherapy or immune chemotherapy, because it's obvious for patient receiving target therapy. We don't know an answer. Now, my point is that we never demonstrate this for mutations or for fusions. Usually there is not really activity, but for copy number alteration could be something different.
Yeah, that's one of our hypotheses too. And this might get to that earlier question about why the response rates look different between treatment naive and second line. We think that chemotherapy might also engender some level of MET-dependent resistance. So I don't have data and we're looking at it, but it's not inconceivable to think that rates of MET amplification might rise with even cytotoxic therapy alone.
Yeah, that would be very nice, because actually this would make a huge difference if we can rely on data from first line genome profiling, or we need to make profiling. And copy number alteration assessment on liquid biopsy is not trivial. I mean, it's quite complex and it's not obvious to get a reliable result. So if there is no other question for Jürgen, I will thank you very much, Jürgen, for your talk, and I will leave the floor to Alex Dillon to talk about RET and then TRAC, other two interesting targets for non-small cell cancer.
Thanks very much, Nicola, and thank you to the other organizers for the invitation to speak virtually today. It would have been lovely to see everyone in person, but hopefully we'll do that next year. As was mentioned, I'm going to discuss targeted therapy for lung cancers that are dependent on RET and TRAC via recurrent gene rearrangements or fusions. These are my disclosures. All right, we're going to begin the talk in the first section by discussing RET fusion positive lung cancers. And this is a very simple schema. The first thing to highlight is what you all know, that these fusions are found in up to 1 to 2% of non-small cell lung cancers, predominantly adenocarcinomas. But as you can see on the slide, and this dovetails with a lot of data that you've heard recently, these fusions are also drivers of oncogenesis across many different tumor types at much lower frequencies. Of course, in papillary thyroid cancers, it's more common than in non-small cell lung cancer, which is why a lot of the drug development programs that we're going to talk about are focusing also tumor agnostically on the activity of these agents. And you've seen the pralsetinib and sapacatinib data showing that there is activity across cancers. Structurally, if you look at the bottom of the diagram, you'll see that this looks like any other fusion where you have RET sit in the downstream 3' domain, including the kinase domain, I should say, in its full length, and then you have a variety of upstream partners. There are lineage differences between lung cancer, where KIF5B is the most common 5' event, versus CCDC6 and NCOA4, which are the more common 5' events in thyroid cancers or papillary thyroid cancers. But functionally, this results in a chimeric oncoprotein that drives oncogenesis. Now, we'll go quickly through what I've spoken about before, a little history lesson, which takes us to prior to 2017, where the only targeted therapies that we had for these cancers were repurposed multi-kinase inhibitors. They weren't designed to inhibit RET meaningfully, but they did have some anti-RET activity, and they were essentially pulled off the shelf and explored in thyroid cancers, and later in many smaller phase 2 lung cancer trials in RET fusions that you see here. So if you look at the bubble plot, In yellow, you have those phase 2 trials, the 4 ones of cabozantinib, vandetanib, and lenvatinib. And of course, it's no surprise that when you look at objective response rate and median progression-free survival in the X and Y axes respectively, that compared to more contemporary targeted therapies for ALK and ROS fusions and EGFR mutations, particularly osimertinib, the outcomes fell short. Now, the second major point that's not on this slide, which I know you're all familiar with, is that the multikinase inhibitors, by virtue of the inhibition of non-RET kinases, result in substantial toxicity. And in the Cabo trial that we led, 75% of patients almost required dose modifications. And so you can imagine that the drugs are also challenged from a side effect profile, but also pharmacokinetically. And we've shown that you can only get to, at best, even with full doses, 50% inhibition of target if you look at plasma exposures of the older drugs. Thankfully, in 2017, as you now see on this slide, there was a paradigm shift towards rationally designed selective RET tyrosine kinase inhibitors. So chemists had actually tried to disentangle the effects of inhibition of RET against the inhibition of VEGFR2 or KDR, EGFR, KIT, other kinases that the older pills hit. And you see in the kinome dendrograms, you have BLU-667, now called pralsetinib, LOXO-292, selpercatinib, which, trust me, are much, much cleaner than the kinome dendrograms for the multi-kinase agents. And these were also more powerful in vitro and in vivo and had better IC50s compared to the older drugs. The question, of course, was whether or not this would translate into the clinic. And the answer was, thankfully, a resounding yes. Here we see the regulatory data sets for LOXO-292 or selpercatinib on the left, and BLU-667 or pralsetinib on the right. The first thing to note is that the regulatory data sets explore the activity both in patients who are treatment naive. On the left, that's broken out for selpercatinib below in the waterfall plot on the lower right. And in pralsetinib, you'll see the actual top-line data updates a little later on in the table. But these were also explored naturally in patients who were heavily pretreated. And just bird's eye view here, you see most patients had disease shrinkage, deep responses to therapy. I'll show you the objective response rates in a second. But what's highlighted here in the different colored bars is that it didn't seem to matter if patients got prior chemotherapy, immune checkpoint inhibition with PD-1, PD-L1 therapy, or in those black dots, even a prior multi-kinase inhibitor, such as cabozantinib or vandetanib. Patients were still likely to respond to therapy in a very meaningful way. So this was obviously a win. I'll discuss the durability data, but both of these agents, as you know, are approved now for RET fusion-positive lung cancers, and we hope that the approvals expand to other regulatory environments. Another question that people ask is, in practice, can these drugs get into the brain? The answer is also a yes. Here you have the earlier data, the waterfall plots of parenchymal or intracranial best objective response to the selective RET inhibitors, where you see many downgoing bars, high early intracranial response rates. I want to share the case in the middle, who is a patient of mine who developed symptomatic leptomeningeal disease after a multi-kinase RET inhibitor, RxDX105. She could not get on to a prospective trial because of that, but thankfully we mounted a single patient use FDA-approved protocol for her of selpercatinib, and you'll see that she had a confirmed partial response, but also complete resolution of leptomeningeal disease, which reminds us of what we've seen with EGFR TKIs, like osimertinib and some of the other TKIs for ALK or ROS1, for example, in smaller series. So these drugs can cover the sanctuary site of the CNS. And one update published here in CCR recently by our group and several others, I'm sure, on the call. Here you see the updated waterfall plot that's overlaid with the different prior treatments, echoing what we spoke about for patients with systemic response. You see the median intracranial duration of response in the Kaplan-Meier curve on the upper right that was not reached. And then on the lower right, you have median intracranial progression-free survival that approached 14 months. So very good batting average within the table, an objective response rate of 82%. So I promised that we'd pull all of the data together, and there were lots of updates from this year that I tried to capture. You'll see the top line outcomes for response in treatment-naive and platinum pre-treated and intracranial response rate, and these look pretty good. So by and large, almost all of the numbers exceed 60%, which we like to see in active targeted therapies. We're beginning to see the durability trickle in with a median duration of response and median progression-free survival that you see here. Certainly not bad. Not quite at the level of what you've seen with perhaps alectinib in the most mature data. But again, as we put on more patients and treat them for longer, we will understand how long these patients can spend on therapy. But right now, the report card is looking pretty good. The next question is what happens at the acquisition of resistance? And we do know a few things. On the left, we will first focus on target resistance. And we've seen that many of these cancers can acquire kinase domain mutations in RET in response to prior selective or even multi-kinase inhibitor therapy. And some of the most recalcitrant ones are shown here in this slide, where you see the RET G810 amino acid substitutions at the solvent from in this patient and many other patients subsequently who were treated with selpercatinib. Now, we are seeing on the very lower left, these next generation RET inhibitors begin to enter the clinic. One that's called out here is TPX-0046 that's currently in clinical trials that has activity against the solvent front substitution. And we've seen other data coming out for other drugs that are either in exploration in the clinic or soon to be explored. So we hope to see a sequential TKI paradigm for these patients. But now moving in a binary fashion to off-target resistance, on the right of this slide, we'll see that sometimes RET will phone a friend and activate a bypass resistance mechanism. In this case, we're seeing the acquisition of MET amplification, which we were just talking about. After a patient was treated with selpercatinib, we treated this patient with combination therapy that includes crizotinib on top of selpercatinib, and we're able to reestablish disease control. Now, an interesting sidebar here, I'm not sure if this was mentioned in EGFR, but we have seen for EGFR mutant lung cancers, the acquisition of fusions that drive resistance. So RET has also played a role in that space. And here we're seeing on the left and on the right, pralsetinib and selpercatinib used with osimertinib in EGFR mutant lung cancers who developed osimertinib resistance mediated by the acquisition of a RET fusion. And if you look at the bigger data set on the right, you see that even if it's a small n, half of patients have an objective response to therapy. And so hopefully we're able to lean on combination therapy for situations like this. So the RET field is looking good. One thing to highlight is that the drugs are well tolerated with, as you can see in the bottom row on the table on the left, low discontinuation rates due to treatment-related adverse events. I will point out that there are some differences if you look across drugs. Selpercatinib, we see more dry mouth, some periorbital edema that we see in patients. And pralsetinib, we're seeing more myelosuppression with the anemia, neutropenia, white count drops, but both of them can result in transaminitis and increase in blood pressure. The one other thing that I'm sure you've seen with TKIs that are given after prior immune therapy is that we're seeing hypersensitivity. This table on the right was hypersensitivity with selpercatinib in patients with or without prior immune checkpoint inhibitor therapy, and you see the number rise in patients who have had prior immune checkpoint treatment, and we see things like a rash or a much more moderate to severe transaminitis in these cases. Before we leave RET and switch to NTRK, the field is evolving. There are new trials. You've probably heard that the original Libretto 001 trial, for example, is being amended to include neoadjuvant selpercatinib followed by definitive therapy inclusive of surgery, and then thereafter adjuvant selective RET inhibition. And there's also a separate trial altogether. I think the number is Libretto 431 for selpercatinib, that's given in an adjuvant fashion for stage 1B to 3A lung cancers with RET fusions. And of course, the pralsetinib program will echo these efforts in different trials. Okay, the last section of the talk will discuss NTRK fusion positive lung cancers, or TRK if you're talking about the actual chimeric oncoprotein. You all know that this is a very interesting space because while these fusions are found at lower frequencies in common cancers like lung cancer that you see in the green dots, they're also found at very high frequencies in rarer tumors like secretory carcinoma of the salivary gland, mammary equivalent, congenital fibrosarcoma, congenital mesoblastic nephroma. They're also found really across different histotypes. So you see epithelial tumors, mesenchymal tumors, the sarcomas, primary brain tumors, and finally, you span the gamut of ages from pediatric cancers all the way up to adult cancers. On the upper right, you'll see that structurally, these NTRK fusions are no different from ALK, RET, and ROS1. NTRK 1, 2, or 3 are the 3 different genes that sit in the 3' position, with of course an intact kinase domain. And we'll skip over that as we've talked about this earlier on. So just to jump to the money slide and save a little bit of time, the first generation TRK inhibitors are larotrectinib and entrectinib. The difference being that larotrectinib is selective for TRK A, B, and C, while entrectinib inhibits ROS1 and other kinases. In fact, it also has been approved for ROS1 fusion positive lung cancers that are TKI naive. You see here some of the data updates. The objective response rates are north of 60% for both drugs. This is in a tumor agnostic fashion, and you'll see that responses are achieved across different tumor lineages. And this is why both drugs have garnered approval in a tumor agnostic fashion, inclusive of adult and pediatric cancers. And we hope that that extends to other regulatory bodies across the world. Durability, nice swimmer plots here. You see that for larotrectinib, for example, astounding duration of response of 49 months, median progression-free survival of 35 months, overall survival not reached. I'm not showing you the Kaplan-Meier's here, but you see on the swimmer plots that there are some patients that are pushing almost 4 years since they got therapy. We are able to leverage local therapy for oligoprogressive disease for these cancers. And interestingly, the label includes non-metastatic disease. So if you have someone with locally advanced NTRK fusion positive lung cancer that's not amenable to surgery or even radiation, within label, you are able to use these TRK inhibitors in order to help debulk those cases. However, it's a lung cancer conference, and I'm fishing out here the lung cancer specific data. These are the updates for entrectinib, larotrectinib. The numbers don't look very different from the last slide, which is encouraging. I will just highlight again that both data sets here include patients with brain metastases that you see in the dark blue bar, in the light blue bar, excuse me, in the upper waterfall plot. And also in several patients in the table that you see in the lower plot for entrectinib, highlighting that these drugs can cover the brain. These are the durability outcomes. Again, for the larotrectinib and entrectinib, on the left, I somehow pulled in, no, actually, these are the lung cancer numbers. So they still look pretty good, especially for larotrectinib. And if you're able to download these slides, you can go through these in detail. Quickly, just showing you a case of mine on the lower left of an NTRK fusion positive lung cancer with brain metastases, confirmed response to larotrectinib, and actually a near intracranial complete response, 95% volumetric shrinkage. And to this day, this patient of mine remains on a TRK inhibitor. Talking about resistance, the same science of on-target resistance with acquired NTRK 1, 2, or 3 kinase domain mutations. We've observed that. There are second-generation drugs like selitrectinib or LOXO-195, repotrectinib or TPX-005. They're also designed as smaller macrocycles to avoid the steric penalties that we see with these substitutions. This is not a lung cancer case, but for those of you who also treat thyroid cancer, this is a secretory gland tumor, salivary, that harbored an NTRK fusion, responded very nicely to entrectinib, thereafter progressed with on-target resistance, and then jumped onto repotrectinib, which was designed to target these resistance mutations. And we achieved response again very nicely, even before doing the first scan. We noted that this cancer was shrinking with treatment. Perhaps the largest data set so far publicly presented was this waterfall plot. That's a typo at the bottom. This is actually from AACR, where we see that across solvent front gatekeeper mutations, we see disease shrinkage with LOXO-195 or selitrectinib. And here we see a suggestion of an algorithm for how to treat these patients. You start with a first-generation TRK inhibitor. If you have limited disease progression, amenable local therapy, then surgery or radiation can be used. If it's widespread progression, at our center, we put a premium on characterizing molecularly how resistance is mediated. And if you see on-target resistance, the clinical trials of both repotrectinib and selitrectinib are currently ongoing across the world. And of course, we have also observed off-target resistance. There are a few cases where we've tried combination therapy for acquired BRAF or MET, but by and large, if you don't have access to combination therapy, I'm not aware of a large trial that's doing this. Standard of care therapy is what we would rely on. Now, in the very last few minutes, we'll talk a little bit about tolerability. Both drugs, larotrectinib and entrectinib, are well tolerated in general. You see here that dose reduction and treatment discontinuation rates are either less than or comparable with crizotinib, which I'm sure you're all familiar with, is a very tolerable treatment in the clinic. There are unique side effects, though, that I want you to pay attention to. These are all mediated in the boxes at the bottom by inhibition of TRK A, B, and C, which are involved in the maintenance of the sensory and autonomic nerves, the appetite and thirst center, and proprioception. So it's not surprising that with these drugs, we're seeing things like weight gain. That's something that we're not always used to seeing in our patients. So make sure you check your patient's weight at every visit. This can get worse over time. And things that you can do beyond, of course, exercise and diet are pharmacologic interventions like GLP-1, drugs, metformin, or a dose reduction. Dizziness or ataxia is something that's seen, and make sure you characterize that, because there are some patients where it's more of an autonomic phenotype where you have the autonomic nerves affected. You might rely on midodrine to help with that, versus those where there's a vertiginous component where you can use a drug like meclizine. But by and large, really the most effective measure here, if your patient's very sensitive, is dose reduction. Paresthesias are pretty mild. They normally occur around the mouth and disappear after the first month, so I won't touch on that too much. But withdrawal pain is something to note. That's when patients temporarily or permanently discontinue a TRK inhibitor, and they can have full body pain. That's because these TRK inhibitors, while you're on them, they can reset your threshold for feeling pain. So if you come off, you're much more sensitive, and patients describe it as, you know, full body myalgias or sensitivity of the skin, and you have to really push through with pain medication to help manage these symptoms. And we can talk a little bit more about this in the Q&A if you want. But in the interest of time, I will conclude. RET fusion and NTRK fusions are certainly actionable drivers of oncogenesis. There are approved therapies across different regulatory bodies. Resistance can occur. Molecular profiling can be done, and you'll find out, hopefully, if it's on versus off target, to help triage patients to next generation TKI versus standard of care or trial. And then finally, the first generation RET and TRK inhibitors are overall well tolerated, but do have unique side effects, which you've heard about today. Thank you very much again for the invitation and for your attention.
Many thanks, Alex. Very nice talk, comprehensive. We start with a question that comes from the floor. Actually, it is a question I was going to make anyway. Any sense that RET or NTRK partner or fusion variant influence resistance the way they do in ALK? Okay, I think that the point is is the partner relevant then to the response to drugs? At least what we know about this now.
Yeah, so we don't have large data sets just yet that corral patients molecularly into bins where we can do a meaningful analysis. I will say that some of the more canonical fusions like ETV6 NTRK3, they seem to have more of a proclivity for durable disease control, but they also cluster in a lot of those rare cases I mentioned where you might have pediatric cases where we think that it's more genomically naive, and so patients stay on a TKI for a longer period of time. In lung cancer, we still don't know, but stay tuned because we have our eye on this.
Actually, these are rare mutations, so it's very difficult. We will need to most likely to treat more and more patients before we can have sufficient data to understand if there is any difference between fusion and fusion. Now, for RET, you have shown the data of activity in lung cancer. There is activity also in thyroid cancer. There are studies ongoing on possible use of RET fusion as a tumor agnostic biomarker. Do you think that there is room for this, or we are far from this?
Yeah, absolutely. We've seen that with both the selpercatinib and pralsetinib updates. I think one of them was just at ASCO, and the other one preceded that, where you're seeing responses across different tumor lineages. So my hope is that eventually the approvals expand a tumor agnostic fashion. The objective response rates do fall below what we see with lung cancer, but I hope that with larger numbers that we'll see a pattern that echoes what we've seen with NTRK.
Oh, that's very interesting. And actually, you have shown that there's room also to use combinations in patients that become resistant to these inhibitors, or rather, resistant to EGF receptor tyrosine kinase inhibitors. However, the point is that almost every patient might have a different, picture, and at least in Europe, it will be very difficult for us to use such combination. I don't think we will never be able to go through phase 1, phase 2 trials with this combination. So how do you approach this? Is it only to clinical trials, or in your clinical practice? How do you approach it? If you have any patient, for example, that adds on a meta amplification to your RET fusion?
Yeah, some of this is happening prospectively. So for example, the osimertinib program, I think they've nominated already a RET inhibitor for patients with acquired RET fusions. However, as you said, I don't think that the trials will read out very quickly because it's not a common event. So what I've done in my practice is I've tried to get insurance to cover combination therapy, or sometimes you write a single patient use trial, and hopefully via things like global registries, if many people are doing this, we can pool the data, and that will help also inform our practice.
Yeah, and now, Jürgen, you have a question, please.
Yeah, Alex, I have seen just 2 weeks ago a young female patient. She was 40 years old. She had a RET fusion positive and a CLC stage 4 with brain mets. She has already been treated before diagnosis of RET with platinum-based chemotherapy and immunotherapy. Then she has participated in the pralsetinib trial, very good response, but after 6 months, massive relapse, also in the brain. It was a very desperate situation. Would you try in such a situation selpercatinib?
So it was progression only on pralsetinib?
Yes.
Yeah. So it's unclear whether or not one drug has a leg up on the other drug in terms of CNS activity. And I haven't seen even preclinical head-to-head data. If there's nothing else, it's not unreasonable. However, there's a drug that's already in clinical trials called HM06 that's supposed to have improved CNS activity. So if you have that trial close to you, I might think about that program.
Okay, thank you. HM06, I don't know it, okay?
Yeah, it's from Helsinki.
Okay, thank you.
But there is only difference in terms of permeability of the blood-brain barrier, or do you think there's a difference also in terms of activity of the two drugs?
Of the new drug, supposed to be increase in activity.
Nice. Now, just to make clear to the audience, should we look for these genomic alteration, for example, for RET fusions only in non-smokers or all patients? Alex?
Yeah, so like with other oncogenes, these are predominantly in never smokers. But if you look at the registries, there are always these heavy smokers that we see in a very low frequency. So I think that we should really put pressure, on payers and hopefully governments to increase coverage for sequencing so that we can do it in a much more broad fashion than we're able to do it now. I've had a patient with a 50-pack-year history of smoking with a RET fusion.
Yeah, and actually, for the screening of these fusions, we know that for NTRK, it's recommended to use immunohistochemistry, at least in those tumors which NGS is not indicated. But for RET, there is no immunohistochemistry that works, best of my knowledge. So one option could be FISH, but in a lung cancer patient, Jürgen, we will have ALK, ROS, RET, and TRK. I mean, this is not feasible. So Alex, which is your thought? I mean, should we go with FISH or we go direct with NGS?
Yeah, definitely NGS if you can do it. I'll quickly point out that we have a recent publication on a RET IHC where the numbers didn't look as bad as we initially thought. I think Heckman is the first or last author there. But in the absence of that, you have to resort to piecemeal sequencing, which unfortunately exhausts tissue, as you implied.
And now there are about NTRK. I mean, you show that there are some peculiar side effects that are really due to the target activity of these inhibitors. Is this difficult to handle? I mean, can you give any suggestion? These are new drugs we are now starting to use in our clinical practice.
Yeah, that's what I thought. I would fold this into my talk. In general, with larotrectinib and entrectinib, these are not difficult to manage. And the dizziness is pretty much mild in most patients. I will say that the toughest one has been weight gain in patients who are sensitive because it's very insidious and it creeps up on you, and 6 months later, 12 months later, they're 60 pounds in. And it's very hard to get them back. So I think I'm trying to get the word out that this happens and you should watch it closely, because if you do something about it early on, then you can prevent the consequences of weight gain. Some drugs like entrectinib have rarely been shown to result in bone fractures in kids who have gained weight. I don't think we've quite seen the same thing in a high frequency of adults, but putting on a lot of weight above your ideal isn't great.
Well, then you have shown data that suggest. Jürgen, please.
Yeah, Alex, Nicola already has asked in a similar way, but what we are thinking about, we have seen the NTRK fusions cross entity. We see you have shown us the RET fusions cross entity. So we have seen MET fusions in different solid tumors. We have now, I have a patient with a pancreatic carcinoma responding very well to crizotinib with a ROS1 fusion. So what is the strategy in your department? So we are negotiating with the health insurance companies to cover for all advanced cancers NGS in relapse, but this is really an expensive activity. And what is your strategy? But I think we should do at least one time, maybe in relapse after standard therapy for each patient with advanced cancer, broad NGS testing.
Yeah, so our strategy is we're still billing, obviously, the billable cancers, but we're relying on philanthropy for the rare cancers or other cancers that aren't billable. But I agree, you have Pembro MSI high, you have NTRK, and as we see more tumor agnostic approvals, we just need to get NGS to everyone else. You're seeing BRCA now in pancreas. We need to interrogate germline in addition to somatic. So it just has to happen because it results hopefully in better care and matching patients.
Okay. Yeah, but actually, the situation in Europe is not that good. We made a survey on all 27 European countries, and the uptake of NGS in Europe is less than 10%. And in some countries, maybe 2 to 3%. So there is a lack of capacity, there's a lack of reimbursement, the system is completely different. So this is something that we really need to improve, otherwise we are going to miss a lot of these new targets. And actually, I was questioning, you have shown that the RET inhibitors works in patients that received also previous immune therapy. But the question is, these patients that have a strong driver, I mean, you have a very high response rate, mostly are never smokers. Do you think immune therapy is working in these patients or is similar to EGFR or because this would be important maybe to assess the genomic alteration, even to refine better the population of patients should receive immune therapy.
Yep, for single agent immune therapy, it's like EGFR now. And we published that our series, we had no responders with RET. And some of them even had higher PD-L1 and median TMBs than other cases. We are putting together a series where we're looking at chemoimmunotherapy. And the numbers might be better there. And if that's the case, if you were to use immune therapy, I would probably advise that you use it in conjunction with chemo. We recently published a paper with ROS1 where we saw the numbers jump when you included IO in chemotherapy. So if you're going to ask me, I would avoid single agent, even if it were high PD-L1, and try to lean on chemoimmunotherapy when possible.
So the idea is that in the oncogene-driven, the chemo can change somehow the microenvironment of the tumor, and that makes more responsive to immune therapy, although there is a driver. I think that's the hypothesis.
Possibly, yes.
Okay, and of course, I guess you are also using a lot of liquid biopsy in your patients. You have data on reliability of liquid biopsy for RET fusion testing. We have seen many papers, but just to come from your experience, and if you have any idea the difference between coverage between different panels. So we have so many panels available, and sometimes our colleagues are confused on which is really the best approach.
Yeah, so RET is actually better than NTRK for the liquid biopsies. And that's because NTRK, especially NTRK3, it's a very large intronic region, the tile where the breakpoints occur. And as you mentioned a while ago for MET, you have the same limitations of being locked into DNA versus RNA. But I think the message is if you find the fusion, then you can trust it and you can use it to treat. If you don't find it and you haven't done other testing, you shouldn't give up. In terms of different panels, I would really just go by the panels that have much more clinical validation data out there. I don't want to name specific ones, but some of the other ones that are coming out have very little data to go by, and I would probably shy away from those versus the panels that have been around for longer with more data.
Yeah, one the problem is that we need to face is that these are very mutation, and when we start to screen, sometimes the oncologist, the medical oncologist becomes depressed because you have to screen many before you find one. We were lucky after we started because we opened a clinical trial. We found one on liquid biopsy. We enrolled on liquid biopsy, was the first patient in Europe, but they are very rare. But still, if we sum up all of them, we get to a significant fraction of this rare mutation. In your experience, both, I mean, how much the use of upfront NGS has really improved the possibility to identify these rare mutations?
Yeah, it depends also on sort of if it's an Asian versus Caucasian population. I think the number, if you add up all the drivers, can be anywhere from 40 to 60%, depending on who you look at and what test you use. And if you use RNA on top of DNA, I don't know, Jürgen, what your experience is.
Yeah, we have started. So our first approach was to build up a network with a lot of referring centers, so that each, so that every hospital or private practice-based oncologist could send tissue. And we started with a normal DNA NGS, and now we wanted to develop into a hybrid capture covering also the fusions, and we saw the publications showing the lower sensitivity. And now the strategy in the moment is to start with in parallel with DNA and RNA based NGS. And so what we see is definitely more of these patients with rare mutations, clearly.
Yeah, and actually this is very good strategy because there are some ideas to start first with the DNA, and if you don't find a driver, then you go with RNA. But then the time, the turnaround time of test is too long.
Exactly.
You miss the patient. I mean, this makes no sense because you can save some money, but you miss a lot of patients. And Jürgen, are you also working with liquid biopsy? Because in Europe, maybe oncologists are less confident in the use of liquid biopsy. What do you think about?
So liquid biopsy, I think there is a problem with the sensitivity of fusions. And so liquid biopsy is used in our centers mainly in the situation of relapse. So in the first so the major approach is really to do a tissue biopsy with broad DNA and RNA-based NGS testing upfront. But if we have a patient who is referred to our center, for instance, with a TKI resistance, then we do the liquid biopsy. But if the liquid biopsy is negative, then we do the tissue biopsy.
Yeah, but I've seen data also from colleagues in UK claiming that there is about 10 to 20% of patients for which they don't have tissue yearly to make genomic testing. And actually, what was referred to me that in UK, 10% of possibly lung cancer patients receive treatment with the chemotherapy, even without any diagnosis of cancer, because they don't manage to get the biopsy. Don't think that in these patients it's worth to use the biopsy up front. I'll tell you that we do that, and if we find mutation, we do treat the patients. We have more probably the KRAS, maybe because of this story of clonal hematopoiesis, but at least in my hands, we are checking also on peripheral blood leukocyte. We never find it. But for fusion, the problem is not there, because for fusion, if you find the fusion might not be an artifact. So,
okay.
Alex, do you have also patients that are treated just on liquid biopsy first line, or you have tissue for all patients?
Yeah, it's the same algorithm. Go for tissue if you can. If it's not safe and feasible to do a biopsy or dangerous, then we do liquid. And if we find an oncogene, we use the liquid biopsy alone to treat if there's no other choice.
Yeah, the last comment I would to ask you, Alex, is that we all were impressed by the last data we presented at the ASCO, because we are used to see all the data coming from all the academic centers with 90% of patients screened for all the genomic alteration or the biomarkers in lung cancer. Then came up here, we have a large community hospital in only 50% of patients that are tested for 5 biomarkers. And this did not include RET and DRAC. So I don't know what I meant. So what happens if we move to that and KRAS? So do you think that is really a need of action, not only in Europe, maybe also in the States, really if we want to take precision medicine to the large fraction of our patients?
Yeah, absolutely. And ASCO had focused on equity and trying to get access to sequencing to more patients. Definitely in the community, there's a big step down. So the papers that you see published are from the academic centers where, it's kind of the ideal world. But out in the community, there are issues with uptake, sort of willingness to do this. Sometimes there are things like clinical pathways, so you only are locked in a particular assay and you can't interrogate everything else. But it's a big problem that needs to be solved in the US as well.
Okay, so Jürgen, do you have any other comment?
No, not at the moment. It was very thoughtless discussion. I think we have addressed most of the interesting points. Yeah.
Yes. So I want to thank you both, for the excellent presentation, but also the excellent discussion. Thank you very much. You are always welcome in our events, and we hope that next time we will be able to host you in person, because I'm from southern Italy, from Naples. We are people that we like to contact, the physical contact, and the fact to have all these virtual meetings we don't like very much. In addition, maybe you could enjoy also some of the Italian weather food in this period that is particularly good. So now, having said that, thank you all for the attendance to this session, and I will leave the floor to Cesare Gridelli for next session. Cesare.